The initial data that was presented on lenvatinib in combination with everolimus was presented by Bob Motzer approximately 4.5 years ago, utilizing lenvatinib and everolimus after patients progressed on a first-line tyrosine kinase inhibition. Patients could have received 2 lines of TKI therapy. Utilizing the dosage of lenvatinib at 18 milligrams daily along with everolimus at 5 milligrams daily. It was a small phase 2 clinical trial, albeit impactful clinical trial. It did have patients have a progression-free survival of 14.6 months, a response rate at 37%, with the patient having an improvement in overall survival. It was a clinical trial comparing lenvatinib plus everolimus compared to single-agent lenvatinib compared to single-agent everolimus. That seemed to not only reveal the benefit of lenvatinib, that being a multi-kinase inhibition, both to VEGF, FGFR, as well as to KIT and BRET, but it also has now led to a lot more studies looking at lenvatinib as a second-line therapy that was presented at ASCO 2020 in combination with pembrolizumab, as well as ongoing clinical trials utilizing lenvatinib as a first-line therapy. Discussing the uses of lenvatinib in combination with everolimus, things to remember: everolimus we have used for greater than 10 years as a single agent for metastatic renal cell carcinoma. The dose of everolimus as a single agent is 10 milligrams a day. On the clinical trial comparing everolimus to lenvatinib, to the combination of lenvatinib and everolimus, the single agent dose of everolimus was 10 milligrams. However, in combination with lenvatinib, the dose of everolimus is 5 milligrams. When you look at the toxicities profile of the lenvatinib and everolimus, the everolimus does cause peripheral edema, causes stomatitis, pneumonitis, can cause laboratory changes in regards to lipids and glucose. While everolimus, as a tyrosine kinase inhibition, we are familiar with its toxicities being GI, diarrhea, taste changes, hand-foot syndromes, hypertension, poor wound healing, bleeding, risk of thrombosis. And if you're on the clinical trial or if patients are receiving combination of everolimus and lenvatinib and toxicities do ensue, based upon our experience, you can kind of differentiate which therapy has to be adjusted. For the most part, the toxicities is mostly going to be the lenvatinib. Dose reductions would go from 18 milligrams down to 14 milligrams, still maintaining everolimus at 5 milligrams daily. You can then decrease the lenvatinib down to 10 milligrams and subsequently down to 8 milligrams if necessary. If you had truly defined the toxicities being purely everolimus, one can actually hold the everolimus, maintain the lenvatinib at that present dose, then reincorporate the everolimus back into the combination profile. It is utilizing 2 mechanisms similar to how we're utilizing TKI and IO therapy. I think at times if one has the ability of utilizing a 2-mechanism agent fighting a disease, when one has concerns of second-line therapy and rapid disease progression, the maintenance of having both agents may be quite important to have the patients have a good response and a durable response as well. On the patients receiving the combination of everolimus and lenvatinib, the benefit of the therapies leading to improvement in median progression-free survival as well as response rate was truly indicated based upon the patient's good tolerability of the therapy in combination. Most of the patients were able to maintain the doses of lenvatinib. The patients upon toxicities of lenvatinib were mostly reduced to 14 milligram a day from the 18 milligram dosage. Patients were able to maintain on the everolimus at 5 milligrams a day. And I think it's important to recognize, despite the second-line TKI therapy, and even though one believes that if you had toxicities from the first-line TKI, you will subsequently have toxicities from the second-line TKI, TKIs that tend to be different despite the fact they do have some overlapping inhibition of VEGF. The tolerability of the therapies are still considered to be individualized, and I would say that in my practice, when patients do switch from a first-line TKI to a second-line TKI, I still utilize the therapy at its PI dose, at the standard dose of initiation, with dose adjustments based upon toxicities. And I think it's important that recognizing a lot of the data that's been presented over the course of the last 13 years utilizing TKI therapies, we're utilizing patients at the initial starting doses based upon clinical trials.